Conflict continues to affect our world. Some 1.2 billion people are estimated to live in fragile and post-conflict states. And the proportion of the world's poor living in these settings is large and growing, projected to reach 50% by 2018. Health systems are severely affected by conflict. Conflict creates change and disrupts the balance and relationships between the supply of healthcare services and their ability to meet the health needs and demands of the population essential for a health system to work effectively. The health system becomes fragmented, constraining the supply and availability of healthcare services. Demands on the services are also challenged, as the health needs of the population change because of conflict and fragility affecting all aspects of life. Combined, this makes for a vulnerable and fractured health system. During and immediately post-conflict, formal access to healthcare breaks down. Even emergency assistance often fails to reach people, so the main source of care comes from whichever local and indigenous health providers are present. But what do we know about the best process of rebuilding health systems post-conflict and the effectiveness of different approaches to health systems strengthening and equitable access to healthcare? Through its research in post-conflict and post-crisis settings, ReBUILD is trying to improve access to effective and equitable healthcare and reduced health cost burdens for all women, men, girls and boys by understanding more about post-conflict health systems, especially health financing and the health workforce. With ReBUILD's focus on poverty, gender and equity, this work will support achievement of several of the Sustainable Development Goals. The universal set of goals for 2030 to end poverty, protect the planet, and ensure prosperity for all. In the post-conflict environment, so far our work has highlighted three core themes to rebuild stronger health systems: institutions, health workers, and communities. Firstly, the institutions, that is, the organizations, rules and relationships that apply to the health system, become more complex post-conflict and post-crisis. There is a rapid influx of actors and resources. Decision-making can be uncoordinated, meaning that resources can be inefficiently used, duplicated, and fail to deliver the right services. A key issue is the lack of ownership of national actors during the immediate post-conflict period and afterwards, which, coupled with the uncoordinated approach, can make long-term health system strengthening more difficult. Decisions made at this time can impact long into the future. In the second theme, ReBUILD's research shows that conflict forces staff to flee or adapt, or it may be too difficult for them to work. All this affects the delivery of health services. Staff can show great resilience. Often they innovate to continue providing services when core facilities, resources, and funding are lacking. HR policies and systems for health workers are often driven by external players in the post-conflict period and don't address the realities of low financing, conflicting political priorities, weak institutions, patchy implementation and gender inequities. ReBUILD's work shows the importance of the knowledge and commitment of staff and local-level managers and how this can be supported. Local staff and mid-level cadres, commonly female, have shown more willingness to stay in remote areas in some settings. ReBUILD's work shows how policy and practice could support more effective deployment and retention of staff in underserved areas for the long-term post-conflict. While ReBUILD's first two themes are related to the supply of health services, the third theme concentrates on the demand, that is, the needs of the communities. Household structures change. In many conflicts, men are significantly more likely to die than women. Conflict can create a missing generation. The lack of men in households reduces reproduction, and the fractured health system increases child mortality. Conflict also exacerbates vulnerabilities. For example, by increasing the prevalence of disability and of female-headed households that may be disadvantaged in labour markets, and of households and extended families that are missing a generation through war-related deaths, abductions and migration. These vulnerabilities create new needs for the health system to respond to. Sometimes these are also sources of resilience. Female-headed households have been shown to prioritise health expenditure more than male-headed ones in some settings, even though they may have less to spend. During conflict, the fear of moving around restricts access to healthcare. Post-conflict concerns shift to aspects of the financing and accessing of healthcare. This fear reflects two areas: the unpredictability of the cost of healthcare and often lack of awareness or poor implementation at community level of policies and fee structures, which can undermine access for certain groups, like widows. The changes to household structure undermine some of the ways extended families manage healthcare costs. They can also restrict their use of mutual community support mechanisms, which often enable the poor to access healthcare, more so than government or NGO initiatives. The three core themes are interdependent. Changes in one will have direct consequences on the others. So, an overarching understanding and interlinked approach in these three areas of the post-conflict context is making an essential contribution to building responsive and resilient health systems. Find out more about these themes and how ReBUILD's research can help drive the right decisions for stronger health systems and better healthcare outcomes in post-conflict and post-crisis situations.